Is there anyone in Barbados who has not been touched by the services of our hospital in one way or another? Perhaps the answer is no. It is here where all of us could seek refuge in times of medical emergencies and expect good service. Since its opening on November the 14th, 1964 to address the medical, surgical, clinical and treatment needs of the Caribbean and to serve as a teaching hospital for those seeking a career in the medical profession, the hospital has expanded its many services and programs to meet the demands of the population and to keep pace with times. This is our hospital. In this new series, you will be kept abreast of the many services and programs offered by this healthcare institution. You will get to see the operations of a number of its departments, and you will be exposed to the processes that are to be followed when accessing its services. This is our hospital. This episode begins with Minister of State in the Ministry of Health and Wellness, Dr. Sonia Brown, as she speaks of the recent success stories of this institution since the COVID-19 pandemic.
QEH, I am pleased to say, has made strides over the last few years. Indeed, so after the pandemic, we are now rising out of it, as you say. We've basically hit the ground running since the pandemic has eased and the numbers of COVID has eased and the severity of infection is also better. There's good news. I know QEH is a low-hanging fruit when it comes to criticisms, but we've been doing well. I will proceed to give you some examples. I don't know if there are any areas in particular you want to ask, but I will tell you the main areas that we've progressed really quickly are with respect to the cataract surgeries. We've now restarted joint replacement surgeries. We've added staff. Not many, but we've added staff to make the impact a little more noticeable. We are working on initiatives to improve the A&E department. Our surgical department has improved greatly, and I thank the staff for this. So the efforts are ongoing, and we are really making headways.
That is very good news. Now, users of the Accident and Emergency Department often complain of the time they spend seeking to access the services there. Dr. Brown walks us through the process.
One of the problems is the patient might come, then the delay may be on an ambulance trolley. So then that delays the ambulance from getting out there to bring in other people. All right, we've decided that the x-rays are done, sometimes there are delays, and the lab work is done, sometimes there's the delays in the lab getting back. We're addressing that now, getting back the results. So it's not necessary. People say that they're waiting for hours, and a lot of cases are legitimate. But when you consider that you come, you wait for your triage system where we decide who is urgent and who is not urgent. Then you see the doctor. Then you have x-rays. All of that is time that the patient is being looked at. You have blood tests. We are waiting on blood tests. We are waiting on the radiology results. All that has time spent in A&E. Then we are waiting on a bed. So it takes a referral process where we speak to the head of department or whoever on whichever department, medicine, surgery, obstetrics and gynecology, all those, ENT, whatever. Sometimes the wards are actually full. Our bed capacity, from what I remember when it was here, was like 24 patients per ward. That does not always ring through. When I was here some 20, and I will leave it at 20-something years ago, we always had a spillover bed. So although you have a 24-bed unit, you may have 26, 27, 28 patients on this unit.
That takes us directly to the bed management system and what is involved in that approach.
The bed management system is a system where we can expedite the admissions and the discharges of patients into the hospital. Over time, we have found that sometimes patients take a little longer than needs be to be discharged from the hospital. So then at least a backup, for instance, within the accident and emergency department. So if you don't have a bed, the input of the patients getting onto the ward is delayed. So the idea behind the bed management is to make daily rounds, and now it's a 24-hour system, I'm told, to make daily rounds to ascertain which patients can be discharged a little earlier. So for instance, if a patient would have been planned for a 5-day discharge. We can now get it down to 3 days depending on how. So this team actually hits the wards, goes around per bed, does rounding with the nurses and so on to decide if patients can be discharged early, thereby freeing up the beds. So that is basically how that part works. So if the beds are not cleared, there's a delay. What people do not tell you, we have until the A&E is fully built, because you know there's a phase 2 that we're waiting to have done. We have a separate ward, so to speak, on another floor where patients that could not get on the ward are being seen. So you are officially admitted, but it might mean that you're not officially on the ward. So patients may be any that are actually admitted and are being seen by the doctors from that particular department. So we have addressed issues with staffing. We've not addressed, we're looking at issues with staffing. So it might get to a point where we need a couple more doctors, a few more nurses to fill in these spaces where we see a delay. We are consulting with another institution abroad to see, and the doctors know where the shortfalls are, to see how we can make it more efficient. Yeah, so there are issues like that. We need to sort out the wait times. There's no hiding on that. We need to delve into it, and we're doing that right now. We, as I said, being the management.
The wait time is an issue. Dr. Brown mentioned the categories that we see in the A&E. Some patients who probably should not be utilizing our A&E as primary care service. And the target then is the long wait, so that we keep patients' families on the outside informed. What is happening with grandma, what's happening with my dad, my mom, in terms of the throughput, or what we call the patient flow through the A&E. And they're going to be the voice on the folks on the outside. As you know, as patients come in the A&E, we maybe have to stop our throughput because of severe injuries. Lately, we've been getting a lot of trauma, and they are categorized as number 1s and 2s. These are emergencies that we have to, so the weight factor is multifactorial. It's not really due to one specific, but many things that are happening, and as you can imagine, in an area that's deemed to be emergent and or urgent care.
If we could get the rest of the hospital improved, the A&E would see better efficiency. So, and I understand, I really understand from the perspective of the patient what they're feeling, because you're ill, you're not feeling well, and it might not necessarily be what medical staff might be considered urgent, an urgency or an emergency, but sick is sick. And that's the other problem with A&E. We tend to see the majority of our patients are the less urgent, the majority. The urgent ones, category 1, are seen almost immediately, category 1, category 2. We have patients in their 5 categories, in the lower categories, or if you want to say lower, higher categories, that can be seen in the primary care setting easily without having to, and they contribute to the backlog. So say I was playing football, in which world, and got a bruise on my knee. There are patients that still come to the A&E. No, that's a primary care issue. That can be fixed in either the private institutions, in the polyclinics if it's a daytime issue. We have patients coming into that, to the A&E for something like that. So that makes the backlog a little more miserable. You have patients that are coming in for things like dysmenorrhea, period pains, if I may say so. Severe, obviously severe, but this is something that does not necessarily need and as an emergency of a tertiary care institution to address. So the onus is on us basically to get the word out on what is hospital priority and what can be addressed outside. So all of this comes in with outfitting the primary care services. So if we could get some of these cases that are not so emergent or so urgent to go to the relevant areas, it would help a lot with respect to the backlog. But this is the psyche of the Barbadian person, especially if you get sick in the night. You want to run for help, especially if it's a pain problem. So the natural process is to come to A&E. So we have to work on the public with respect to that. And then we'll have patients that there would be a few that are dying. I spoke to one of the consultants here, and we have to start educating the public that it's okay to die at home, for instance. It's not necessary, yes, you panic, but you don't necessarily have to run to A&E. If you know the patient is at end of life, you have to start educating the public on what to look for and how to manage it at home. So these are little things that give the A&E bad rep. Some is on us, but some is on the public as well. So we both have to take the fair share.
This reinforces the need for an educational program. From time to time, we hear of the unfortunate cases of elderly abandonment when no one reports to the hospital to receive the discharged elderly individual, and he or she is left on the ward.
There are two peaks where we see the majority of those coming in. Crop over time and Christmas time. You could put the pieces together. I leave that to you. So basically, old people or young people who are sometimes disabled and so on are brought to the hospital with illness. However, they got ill, but with illness, they have to stay, sometimes overnight, sometimes to be admitted to the ward. And when it's time for discharge, you cannot find the relatives. They give fictitious information on how to contact them. And sometimes there are cases, and I will not cry down everybody. Sometimes, and I don't want to use the word justification, but there's some people that have been struggling for ages to look after their loved ones that have reached that stage. So you may have a family with 5 people in the house, including the elderly person, 4 of them working. There's nobody to take care of them. And sometimes it's a case of desperation. If it's I'm the only daughter and my mother is there and I have to go to work and I can't get home to feed her and to change her diaper and so on, there is desperation. But we have to bear in mind there are other agencies other than the hospital that you can seek help. There's the National Systems Board, there's private institutions that they can admit the patients in. So we are inundated with fairly high numbers of this category of people in the hospital. So obviously they take up beds, and that's one of the issues that will always trickle back down to A&E. They take up beds, they take up resources, because the costing of keeping a person every day is fairly high. It's actually higher than if they were in a nursing home for daily care. Feeding, the doctors still have to go to see them to make sure they're okay. Bed sores kick in and they have to address those things. So this needs to be addressed. We have been having good help, and it will never be enough, but good help from the geriatric hospital, but the numbers keep rising. So right now, even Harrison Point is people, young or old people got COVID, had to be taken to Harrison Point. We can't get them out, can't get them back home. So that has to be addressed, and it has to be outside the purview of QEH, because at some point, Ministry of Health will come in with respect to geriatric care and so on, but there are other agencies that have to deal with a part of this. So this is one of the issues that we are facing in terms of the backup in A&E and within the rest of the hospital.
The lesson from that, please, please do not abandon your elderly relatives here in this hospital. A few moments ago, we heard from the Chief Operations Officer, Dr. Christine Greenidge. For those of you who are not aware, she is a Barbadian who has a keen interest in playing her part and raising the healthcare standards at all times. Who is Dr. Christine Greenidge?
Yes, I'm Dr. Christine Greenidge, and I just want to share that I was born here in Barbados and left the country when I was 9 years old, moved to New York City with my parents. Recently this year, I retired from the New York City Health and Hospital system, where I worked in various capacities, the last being the Associate Executive Director of Patient Care Services and Nursing. It was always a desire for me as a native Barbadian at some point in my life that to have the opportunity to come back and give back of some of my experiences, especially my healthcare experiences. And so given the opportunity to come here at QEH in the role of the Chief Operations Officer is something that I really and truly look forward to. And I can say that, you know, my family, friends, and, you know, why are you going back, where are you going back? And it's a personal journey for me. And it's something that the least I felt I can do whatever I can bring to QUH, bring to my country in terms of improving healthcare is something that is a passion with me and in my heart. People want to know why I came. I came because I wanted to come. My husband supported me, my family supported me in that, and I am very happy that I've come. I have received warm welcomes. I didn't get really pushback from the folks here. I must say that the staff I find extremely committed and dedicated to what we do. This is who we are at QUH, employees who are caring, employees who are dedicated, and I think employees who now, many have internalized that whatever they do, in whatever capacity, I could be a maid, I could be the general worker, the nursing assistant, the physician, whatever we do, my job title, it has to be connected to the patient.
One of the bugbears we were experiencing over the last few years, I dare say, was the delays in surgery. So you have patients calling into the programs, patients writing into the newspapers, calling the ministers and even the Prime Minister, complaining that their surgeries have been called off after fasting a whole day, or after 3 months appointment they show up and then surgeries could not happen for various reasons. We have looked into that. We have a Chief Operations Officer now that has really been working really hard. And she has found that there are delays with respect to the on-time start of surgeries, and that you could appreciate if you're scheduled for 8 o'clock surgery and it doesn't start till 10, it destroys the whole day. So we've improved greatly on the on-time starts and surgeries.
And it took some background exploration in terms of, number one, on-time starts, which we have defined as those cases that are in the OT room at 8 o'clock in the morning. Secondly, we look at factors related to our staff, on-time staff, whether it's our surgeons and our nursing staff or anesthesia staff. We look at those metrics. And then factors related to the patients themselves, which oftentimes for canceled cases will be improper preparations, for example, or some change in the medical status of that patient overnight that will warrant the necessity to cancel a case. So putting all that metrics together, and this was done based on all the specialties that will perform surgery in our OT, and then presented the data very objectively in terms of a performance improvement plan. We also look at inventories and the supplies and equipments that we will need to ensure that our surgical cases that are planned will go about uneventful. And that took some time, but looking at the aggregation of the data, there were things that we identified we needed to do. First is that a case scheduled for 8 o'clock needs to be there beforehand so that it doesn't impact the turnaround time of that particular operating room. Secondly, have to have conversations with our surgeons that if you wanted or you received a booking at 8 o'clock for your patient, then you need to be here. That wasn't easy, but you need to be here ready to go so that that patient procedure is on time, because we have other cases booked in the room, and then our turnaround time of the room utilization will not be impacted. So those were the background things that we had to do to objectively look at data and make the data work in a more proactive way.
The nurses are on board. We have the adequate numbers in most cases of nurses for the theater. So things are running smoothly. I might add, and I will segue to this, one of the complaints that we've been experiencing is the delay, or the absence, I should say, for some 10 years of joint replacement surgeries. And you could appreciate our community, we have a high elderly population. So with that, other than the other issues that people normally have with joints, so with that comes the arthritis, the non-communicable diseases, and here I put in things like that destroy the joint, lupus and other rheumatoid arthritis, those kind of things that are not communicable. These diseases affect the community. So what we have now were a number of people that were unable to work. So we lost that, unable to provide for their families because they just could not move. they became, I want to use a better word, but a burden, for instance, on our national insurance scheme, because if you're out sick, you have to be paid. They had already injected funds into the NAS. You have to feed the children. So we delved deep into it, we being the management of the hospital, of course, the board, the chief operations officer, the CEO, delved into it. Along with the doctors, we had many sessions where we actually sat with the orthopedic surgeons and came with a plan. So we have started. I'm happy to say the first patient went in. I was there to wish her well and everything, to see her going into the theater. I'm happy to say we've started with the knees. There are, I think, 2 hips on schedule. So we expect these people, usually after orthopedic joint replacement, you're up maybe by the next day or the day after that. So we're looking going forward to keep adding to this role. Right now we're working on getting the numbers up, because as you can appreciate, over 10 years people would have died. People may have gone to get the surgery privately. So we have to get the numbers in. So you will hear more about this, but the idea is to advise people out there, patients who have been on the list, to contact their GPs or whoever their private doctors are, make sure that they're healthy. Healthy meaning fit for surgery, and then be re-referred to the hospital. So that is one of the other things we will bring out, to just inform patients what to do next. So I'm happy to say that has started. 10 years is a long time for people.
In previous years, discussions surrounding cataract surgeries here at this hospital focus on the extended delays in having them done. Yes, there was a major backlog. But thanks to the efforts of the officers here at the hospital, Dr. Brown has some success stories to report.
We have covered over 60% of the backlog. So that's one of the pluses that we have in that department. And I'm happy to say the ophthalmology department has been really efficient. They've been able to do it on their own without intervention from abroad. Remember some years ago, I think the Cuban doctors came in to help, but we were able to do it. And I'm really, really, really proud of them and the efforts that they're making thus far. So the public should be happy to hear that. And of course, the work goes on. It's not only the backlog, so patients were constantly being referred and so on. What I would like to see to help with that is in the primary care setting, and that's also to some extent my area, a better outfitting of the ophthalmology services in the primary care setting. When I say primary care, the public primary care, the polyclinics and so on, to see if we could build those out a little more to address some of the issues with eyes, not only cataract, the issues with eyes that do not necessarily need to make it to the tertiary care setting, i.e. into the hospital. Some of the issues we had was equipment, and obviously you can't do cataract surgery without the equipment. We have passed that stage long ago. You would say that there's the Lions Eye Care Clinic, but we have faced some issues with respect to the roofs. We're working on that to get the monies for that. With respect to the roof, we could not operate the theaters in there because the ceilings and so on had to be, or have to be fixed. So we made a plan basically to use other theaters along with a small one that they have, other theaters to get the backlog addressed. So the doctors basically came together and the consultants and so on and decided this is how we will tackle it. We provided the equipment, they decided on the schedule, and they were tackling at least 80 per month. The plan was to tackle at least 80 cataract surgeries, barring something happening. Sometimes you have patients that come in on that day and then we find out their blood pressure is high or the sugar is under control, so they have to be rescheduled. So you still have to bear in mind that there are legitimate reasons why surgeries could not be had in every area, not only ophthalmology. So they set about giving me a plan on what they would cover. The nurses were put in place, and you know we had nurses coming in to improve the complement of nurses generally in healthcare. The nurses were put in service, and we were able to tackle it from that point of view. We will looking to repair the Lions Eye Care Clinic, and that will lend to the efficiency of the department, because now they will have their own center, without having to encroach on the general theaters to get their services done.
This has been our hospital, This episode focused on a number of success stories, and it took a look at the way forward. I'm Sherwood McCaskey. Goodbye.